We will start now the hematology session. Due to some flights dates, we will postpone the lecture of Professor Ihab Hanafi to the third one, and we will start with Professor Dr. Safa Ramadan, Professor of Medical Oncology in the National Cancer Institute. Safa is doing many things abroad. She will introduce herself.
Good morning, everyone. It's really a great pleasure to be with you today, and I would like to thank the organizers for inviting me to this important conference. The topic of my talk today is bispecific T-cell engagers as an emerging therapy in the management of non-Hodgkin lymphoma. So through the coming 20 minutes, I will try to provide you an overview on the role of bispecific T-cell engagers in the management, mainly focused on pivotal trials that resulted in approvals in diffuse large B-cell lymphoma, follicular lymphoma, and also the advancement in mantle cell lymphoma. I will start with short introduction for the unmet medical need in non-Hodgkin lymphoma, going through the historic development of T-cell engagers. So as you all know, lymphoma is a heterogeneous disease. Just to remind you, sorry, this is going fast. So to remind you that diffuse large B-cell lymphoma is the most common aggressive form of non-Hodgkin lymphoma, representing approximately 39 to 40% of non-Hodgkin lymphoma, while follicular lymphoma represents the most common indolent form of non-Hodgkin lymphoma, up to 20% of non-Hodgkin lymphoma. Mantle cell lymphoma represents 5.5% less common than CLL, but it is also the focus of our topic today because advancement of T-cell engagers is much rapid in mantle cell compared to CLL, which is more common due to safety concerns. You all also know that during the development of B cells, there is a vast majority of specific antigens that go through different stages of maturation and differentiation. And if you look at the right side of the slide, you can see that CD19 and CD20 are considered two stable antigens that are expressed across different stages of differentiation and maturation. Therefore, they were the focus and very important potential therapeutic targets. The story of development of monoclonal antibodies started in 1975 with the NCI research group started to develop a number of monoclonal antibodies, but the success occurred only with advancement in different novel technologies. And indeed, the first monoclonal antibody against CD20 that was proved to be effective and also safe is rituximab, that with FDA approval only in 1997. To remind you with the mechanism of action of rituximab. Rituximab has an FC portion, and the first mechanism is by activation of complement system, so complement-dependent cytotoxicity. Through its FC portion of the antibody, it activates and recruits natural killer cells, causing antibody-dependent cytotoxicity. Through the same FC segment, it attracts macrophages, and together with the linking to the free fragments of complement, starts phagocytosis by macrophage, which is another form of antibody-dependent cytotoxicity. The other mechanism of cell killing by rituximab is through the cross-linking of different rituximab molecules on the tumor cell, resulting in direct apoptosis. Despite the advancement in the management of non-Hodgkin lymphoma over decades, we still have a huge unmet medical need in the management of these patients. If you look at the left side of the slide, you can see that up to 25% of diffuse large B-cell lymphoma is still considered difficult to treat because these patients really have dismal overall survival and also event-free survival. And these patients include primary refractory, patients refractory to salvage therapy, and also patients who progress within 1 year of autologous stem cell transplant. These curves, of course, changed with CAR-T, but I will give you a comment on that in the next slide. If you look at the right side of the slide, you still see that 20% of follicular lymphoma patients who are considered with a chronic disease, they have a really poor survival if they progress within 24 months from start of treatment. We consider these patients as primary refractory. Mantle cell lymphoma, despite the advancement in novel therapies and in specific BTK inhibitors, covalent and non-covalent, still a good number of patients, and at 4 years, you still have more than 25% of patients are progressing and discontinue treatment. These patients in this meta-analysis, you can see that they have really very short overall survival of 8 months, and in some studies, even 4 months. This changed with the introduction of CAR-T indeed. However, the problem is CAR-T is associated with significant immune-related toxicity, including neurological events in more than 30%, cytokine release syndrome in 15%, and even sometimes more in patients with high risk, cytopenias in 94% that are sometimes very prolonged, neutropenia in 85%, and infections in more than 1/3 of patients. The other issue is this therapy, despite its success, it's not widely available, and many centers till today still don't have the capacity and resources to provide the process of T-cell depletion and then T-cell engineering for CAR-T therapy. So, indeed, we have done success in immune-based therapy, but unfortunately, this was coupled with significant toxicity with CAR-T cell and also lack of wide availability across different centers for the ordinary patient in public hospital or in small centers. And therefore, this opened the way for other immune-based therapy, and you can see here in the center the development of bispecific T-cell engagers. Bispecific T-cell engagers, they are very advantageous because they are man-made over the shelf. They are protein molecules, antibodies. They have 2 single chain variable fragments that bind to 2 different epitopes. One epitope to the effector CD3 T cells, the other epitope to a specific antigen on tumor cells. In lymphoma case is the CD20, and currently also the CD19 is already developed, and the first in place was blinatumomab. The characteristic thing in T-cell engager is they lack the activity in the FC portion like the rituximab, because it is silenced by mutation, and therefore antibody-dependent cytotoxicity and complement-dependent cytotoxicity are not part of the mechanism of action of T-cell engagers. And instead, what they do is they interface the effector T cells very close to the tumor cells, resulting in direct tumor cell killing. So they bypass the normal synapse in normal immune response that requires major histocompatibility complex. What they also do is something very important, because they do not activate only T cells within the tumor microenvironment, but they help also recruiting and rechanneling the circulating CD3 in the vascular system into the tumor microenvironment, producing more tumor cell killing. So what are the clinical data that we have for T-cell engagers in non-Hodgkin lymphoma? Before I start the pivotal trials in these bispecific T-cell engager, I would like just to give you an overview on the most advanced T-cell engagers in the clinical development. Mosunetuzumab, glofitamab, epcoritamab, and odronextamab, and plamotamab. They are all based on immunoglobulin G1 format, except odro, it is IgG4. And if you look at the basic clone of CD20 that is produced, it's either based on rituximab or obinutuzumab or ofatumumab, which are the normal currently standard of practice anti-CD20. All of them except the EPCO are administered intravenous, and currently mosunetuzumab is transferring from intravenous to subcutaneous, which is very important in development. T-cell engagers are associated as CAR T-cell with cytokine release syndrome and immunological toxicity like neurological toxicity. However, the development of what we call step-up dosing, which is the use of fractionated smaller doses with time intervals, either within days or within weeks, to reach the target dose, was a key success in the development of T-cell engagers to avoid cytokine release syndrome and neurological toxicity. Most of the epitopes in the development or the structure of these T-cell engagers is one-to-one, one to the CD20 and one to the immune effector T cells, except glofitamab, which was developed by Roche to have 2 binding domains to the CD20 and 1 to the effector T cell to improve the efficacy of this T-cell engager, but this of course raised the concerns about toxicity, and in fact you will see now that mitigation plans to cytokine release syndrome is much more intense with glofitamab. So the first pivotal trial that we have is for mosunetuzumab. It's the first in class that was approved in relapsed refractory follicular lymphoma. The study was phase 2 study. It included patients who were refractory to at least 2 lines of therapy. One of them should be CD20 and the other should be alkylating agent. The dosing schedule was in a cycle of 21 days. They started with first day 1 milligram, after 1 week 2 milligrams, reaching the target dose only in day 15. From cycle 2, they received the full target dose, 60, and then from cycle 3 to 8, they received the 30 milligram as a constant dose. The good thing in this program is it is finite treatment, so fixed duration. It's not treatment to progression as most of the novel agents that are currently used in practice. So patients can stop if they are in complete remission after 7 cycles or receive maximum 17 cycles if they are in PR or stable disease. There was no mandatory hospitalization for these patients, so it's a treatment that can be given outpatient. The primary endpoint was complete remission that was compared with historic control for the same patient population with 14% CR. So the patient population was really high risk population. You can see here median age 60 up to 90 years old were included. They were mainly male patients. They had stage 3-4. They had median number of cycles, 3 cycles. And some of them, despite 3%, but it's a good percentage, for CAR T therapy, and they were primary refractory for CAR T. Prior autologous stem cell transplant in these patients, more than 20%, but what's important in these patients, more than 50% were double refractory to CD20 and the alkylator, and they also progressed within 24 years, so very challenging population. Response rates were very impressive, reaching 80% in the overall population, and complete response 60%, which of course had the triumph for the historic control of 14%. So the study achieved its primary endpoint and therefore was approved by the FDA. If you look at the right side of the slide, you can see that the effect maintained also in patients who are considered double refractory or were refractory within 2 years. What about safety? Mosunetuzumab is considered one of the safe T-cell engagers, and you can see here, and remember this number, 44% of patients had any cytokine release syndrome. The majority were grade 1, 2, and very few, only 1 patient had grade 3 or grade 4 each. The median time for cytokine release syndrome is 5 hours from the first dose and approximately 1 day from the target dose. The duration for the symptoms to resolve was a median of 3 days, and very few patients, 11% and 7.8%, required cortisone or tocilizumab, which is specific treatment for cytokine release syndrome. In terms of neurological toxicity, you can see on the left side of the slide only 4.4%. None of them was grade 3, which is great. Of course, you can expect neutropenia, which is still less than CAR T, in approximately 30% of patients, and also infections. Just to put things in the context with CAR T, you can see here that the median duration of response was approximately 2 years for patients who are responding and was not reached with 18 months of follow-up. So if you look at the 2-year duration of response, 65% was CAR T. So a single agent given outpatient with absolutely tolerable toxicity is advantageous for this patient population. What's very important in this study is you also looked at the elderly population, and you can see here on the left side that patients older than 65 years old, they had very good overall response rate, 70% CR, which is even better than younger patients. And you can see also in terms of safety that patients older than 65 had less cytokine release syndrome in general, and they require tocilizumab and corticosteroids in less than 1/4 of the patient population. So in short, mosunetuzumab was approved in relapsing refractory follicular lymphoma patients, and it was associated with manageable toxicity also in elderly patients. So I will just go quickly through this slide just to inform you that it was also tested in frontline DLBCL in a very challenging patient population, which is the elderly population above 80, or patients from 60 to 80 who have high number of comorbidities. They tested so far 54 patients, and overall response rate 56%, CR rate 43%, neutropenia seen only in 15%, and CRS is 26%, very low grade. And just to remind you, this patient population rarely can receive treatment, only 30% can receive the mini shop and with very poor outcome. Moving to the second T-cell engager that was approved, glofitamab. Just to remind you, it is a novel molecule of 2-to-1 ratio. And in fact, if you look at the pivotal study, that was phase 2 expansion trial in which patients were also refractory to 2 lines of therapy or more, that includes anti-CD20 or anthracycline. You can see that plus the mitigation that is used for all T-cell engager, which is corticosteroid, they used also anti-CD20 obinutuzumab as a debulking and also to be a lympholytic to reduce the lymphocyte circulation to avoid toxicity. They used also step-up dose, and it's an intravenous and finite treatment, only 12 cycles maximum. Primary endpoint was complete remission, also compared to historic control. The patient population is very challenging, even more than those who were treated with mosunetuzumab. You can see that more than 3 lines of therapy was given to more than 60% of patients, and here higher number of CAR T therapy was given to these patients, more than 1/3 of the population, and they were even refractory in a short term to CAR T therapy. So really population that is considered very dismal. Impressive CR rate, overall response rate 51% and 39.4% complete remission. Very short duration to obtain complete remission. And you can see that that study also achieved its primary endpoint because the CR was 35% compared to 20% in the historic control. What's interesting is also that the CR rate was not impacted by previous CAR T therapy, but it was higher in patients who relapsed rather than refractory to the last therapy. What about safety? As expected, glofitamab, and I told you, remember the 44% of mosunetuzumab, you can see here glofitamab reached 63%, and in the recent trial, it's even more, exceeded 66%. It's considerable toxicity, but the majority are grade 1 or 2, very few are grade 3 and 4, and again, the median time from the first dose is 13 days. More patients required corticosteroid and tocilizumab, but overall, none of the patients discontinued treatment or had a fatal event due to CRS, cytokine release syndrome. On the left side, you can see the most common is a cytokine release syndrome, followed by neutropenia, anemia, thrombocytopenia, fever, and hypophosphatemia. You can also see that neurological toxicity indeed occurred even more than grade 3, but again, none of them was resulting in death or discontinuation. So for the sake of the time, just to remind you, these CR rates are very impressive even in prior CAR T therapy. And indeed, on June this year, glofitamab received accelerated approval from the FDA for adult patients relapsed refractory DLBCL. So in short, the CR rate is impressive. It was allowing the study to meet its primary endpoint and resulting in approval. The CRS, despite high, it occurred only in the first cycle and was manageable. Very important just to say that there is also advancement in mantle cell lymphoma, and this is a very hot area of research, and very, very impressive. Overall response rate, 83.8%, CR rate, 73%, even in patients. If you remember, initially I showed you the BTK non-responding patients or progressing patients are very dismal. You can see here that even in BTK exposed patients, you have an overall 75% and 67% CR. Just to remind you, pirtobrutinib, we were all happy that pirtobrutinib was approved in mantle cell lymphoma. It provides only 50% response rate, and the CR rate is 13% with duration of response median 8 months. The last T-cell engager is EPCO, and it is the only subcutaneous approved in non-Hodgkin lymphoma, in relapsing refractory DLBCL, again, subcutaneous step-up dose. These patients also were two prior therapies or more that should contain patients exposed to anti-CD20. The study met also its primary endpoint with overall response more than 65% and CR rate 39%. And you can see here that progression-free survival in patients achieving CR is impressive. So the FDA granted accelerated approval to EPCO this year in May, and the AMAM approved also, not approved, provided for now positive feedback, and its approval is expected early 2024. So in conclusion, bispecific T-cell engager emerged as a very effective anti-lymphoma therapy. Mitigation plans to CRS and neurological toxicity made them effective and also safe. The FDA granted 3 drug approval in 1 year, which is very impressive. And the field now is moving to 2 areas of research, which is frontline therapy and also in combination with other agents. And with that, I would like to thank you all.
Thank you very much, Professor Safa, for the wonderful delivery of the updates about BITES. Safa, can you accept one question if you have time?
More than one, if the time allows.
Professor Dr. Rafat.
Sure. Yeah, absolutely. That's a very difficult question, but it's the question of the $1 million right now, because everybody, of course, is trying to position T-cell engagers. The vision now is positioning T-cell engagers in 2 main settings. The first setting is when you have a patient with very rapidly progressive disease, and you know that the process for preparation for CAR T-cell takes time, and you need also to lymphodeplete the patient with chemotherapy before doing the CAR T. If all of these circumstances are not available for rapid treatment of the patient, T-cell engager over the shelf, you should do that. The second setting that everybody is thinking is also if you prefer CAR T, but it's not available right now, you can do like bridging. So it might replace CAR T, which is actually what research is going right now to see how to maintain the response, which is all of these studies are early, long follow-up is ongoing, but really patients who achieve CR are impressive. So this is the first. The second thing, of course, not all centers have the capacity to provide CAR T, so T-cell engager will be like the widely accepted approach for these patients. Yeah, exactly. Yeah, indeed. Yeah. That's the weak point in CAR T. Yeah. And also CAR T, one of the advantages, it's one-time therapy, but when patients respond, the response is maintained, almost cured. So the T-cell engagers, now the development is all thinking about fixed duration and finite treatment rather than treatment till progression to be able to compete with CAR T. Okay, thank you.
Okay, thank you very much, Professor Safa.
I would like to introduce my next speaker, Dr. Elisabetta Todisco. She's Director of Hematology and Bone Marrow Transplant in one of the biggest referral centers in Milan, and she's really dedicated to provide her inputs and her own study, which is amazing study in therapy-related leukemia to you. Can I use it? Yeah, okay.
Okay, good morning, everybody, and thank you very much for your kind invitation again for the second year in this beautiful country. So I will, the title of my presentation is Evaluation of Risk of Secondary Leukemia in Cancer Survivors. And these are my disclosures. So therapy-related myeloid neoplasm are secondary hematological complication of chemotherapy and radiotherapy in cancer survivors. So their dismal prognosis due to their resistance to chemotherapeutic treatments, and they can follow any type of primary cancer, hematological and solid cancer, as you see in the graph. And they are associated with specific drugs like alkylating agents and topoisomerase II inhibitors. So in the European Institute of Oncology in Milan, we set up a cytopenia outpatient clinic inside the Women's Cancer Center project. And thank you to tight collaboration with gyneco-oncologists, we asked them to send us for a hematological check women, cured human with previous ovaric cancer or breast cancer, in the case of occurrence of blood value alteration at 2 subsequent checks, 30 days interval, so or leukemia, neutropenia, low platelets counts, anemia, or women with the AOC, so ovarian cancer or breast cancer after stop therapy, but continuing sometimes hormonal therapy as in cancer center. In case of persistence of incomplete reconstitution of one or more hematopoietic cell lines at least 60 days from stop therapy, or in women with AOC or breast cancer undergoing therapy in case of persistence of unexpected and incomplete reconstitution of one or more hematopoietic cell line during therapy intercycle, conditioning a delay in recycling. So what we found out that the majority of these women, the pancytopenic women, were women with epithelial ovarian cancer, and which were in maintenance therapy with PARP inhibitors. And actually in our institutes, we identified in this institute, PARP inhibitors, now they are approved, but before approval, we had numerous active protocol, and the gyneco-oncologist professor she enrolled many patients in phase 1 and phase 2 and phase 3 studies. So in a cohort of 182 heavily pretreated AOC metastatic patient treated with PARP inhibitors as maintenance therapy, has been observed an incidence of therapy-related myeloid neoplasm development of around 8.7%. So, which is the mechanism of action of PARP inhibitors? So, as you see in the figure, endogenous single-strand breaks occurs frequently in proliferating cell and are repaired mostly by PARP-dependent base excision repair pathway. So what's happened? When we inhibit PARP, the unrepaired single-strand break can be converted in double-strand breaks that are toxic to cells, and homologous recombination is the major pathway to repair such lesion during cell replication. So if you inhibit PARP enzymes, in case of homologous recombination deficient cells, cancer cells, through synthetic lethality mechanism, proceed to apoptosis. And this is a very good job for AOC cancer cell, but a bad job for normal hematopoietic cells. So we recently published in the International Journal of Cancer this paper in which actually we identify 16 myelodysplastic and acute myeloid leukemia, over 182 women with metastatic AOC, so an incidence of 8.7%. And 56% of those women were BRCA1 or 2 mutated, and the diagnosis of myelodysplastic of acute myeloid leukemia was made after a median of 18.5 months from starting PARP inhibitor maintenance therapy. These were the cytogenetic and molecular characteristics of the myelodysplastic and acute myeloid leukemia patient. So 7 patients had deletion of 5q or monosomy 5 and or deletion of 7q or monosomy of chromosome 7. 9 of them had a complex karyotype and 12 had a deleterious mutation of TP53. Moreover, we also found premalignant clonal cytopenia named SICUS that now in the new International Consensus Conference classification are an isolated entity called myelodysplastic syndrome with TP53 in the case that the mutation, the variant allele frequency of TP53 mutation is greater than 10. And in our cohort of 5 patients with SICUS, so clonal cytopenia, actually it was less than 10%. The TP53 mutated cases, the buff was less than 10%. So they are still SICUS. And so we started to think about a new project, a biological project, and our hypothesis is that the cytotoxic therapy can promote clonal selection of hematopoietic stem cell bearing a somatic mutation acquired prior or during therapy, and the possible presence of germline mutations in cancer predisposing genes could increase the pool of this clone and favor the acquisition of further somatic mutation. So actually we focused from this real life experience, we focused on epithelial ovarian cancer, and the specific aims of the scientific project were analyze the predictive value of a pre-existing clonal hematopoiesis of specific somatic and germline mutation in cancer predisposing genes for the development of therapy-related myeloid neoplasm, and define the clonal genomic landscape and its evolution prior and after chemotherapy in PARP and or PARP inhibitors in epithelial ovarian cancer patients, and the role of PARP inhibitors for therapy myeloid neoplasm development. So clonal hematopoiesis of undetermined potential is a clinical entity defined by the presence of a clonal population of hematopoietic cell presenting somatic mutations in genes associated with hematological malignancies in absence of evidence of disease. And the clinical threshold for clonal hematopoiesis has been set at a variant allele frequency of about 2%. The most frequently mutated genes in clonal hematopoiesis are those most commonly affected in AML and MDS, like DNMT3A, as XL1, TET2, TP53, JAK2, and SF3B1, etc. And the prevalence of CHIP increases with age. Highly sensitive next-generation sequencing approaches revealed CHIP in 95% of healthy individuals between 50 and 60 years, and CHIP is associated with increased probability of hematological cancer, and the risk is increased in presence of driver mutation, which provide a selective growth advantage and promote cancer development. Recently, this paper has been published, first name Tanya, and in collaboration with our group, so Professor Colombo, which is the head of gyneco-oncologist at the European Institute of Oncology, and also with my collaboration. And the title of this paper is that pre-existing T53 variant clonal hematopoiesis and risk of secondary myeloid neoplasm in patients with high-grade ovarian cancer treated with rucaparib, which is a PARP inhibitor. And the take-home message is that the prevalence of the pre-existing CHIP variants in TP53, but not other CHIP-associated genes at a variant allele frequency greater than 1% was significantly higher in a peripheral blood sample of cases of therapy-related acute myeloid leukemia versus control. And longitudinal analysis showed that a pre-existing CHIP TP53 variants expanded in patients who develop therapy-related myeloid neoplasm following a PARP inhibitor treatment. So this is just to tell you that the germline mutated genes increasing breast cancer risk are often mutated in therapy-related leukemia. And in this paper of Chapek, published in Cancer in 2016, germline mutated genes were found in 20% of therapy-related acute leukemia. Moreover, the recent International Consensus Conference classification of hematologic neoplasm, the neoplasm with the germline mutation, as you see in the table, represent an isolated entity. So we decided to perform a prospective biological study in which we focused on patients with advanced ovarian cancer, incomplete or partial remission after surgery and platinum-based chemotherapy, and eligible for PARP inhibitor therapy. So blood buccal swamp and blood sampling were taken before starting PARP inhibitor maintenance therapy, and after blood sampling, so peripheral blood sampling, every 6 months thereafter. So we performed a genetic analysis by specific custom gene panels. We used 2 different custom gene panels. The Mielo panel, which is a large panel comprehensive of 256 genes and usually mutated in myeloid neoplasm, and comprehensive of actionable genes, IML, cancer drivers, hematological disease risk genes, and pharmacogenomics SNPs. And another custom panel which was used and specifically to study clonal hematopoiesis, which is called CHIP-YUMI panel, and its characteristics, it's a very high sensitivity till 0.11% variant allele frequency. Then I'm not losing time. We decide, of course, a filtering strategy for mutational analysis. With the help of our informatics, and then a classification of clonal hematopoietic mutation and potential drivers hematopoietic mutation on the base of the literature. And until now, we enrolled 50 patients, and 43 were available for analysis at different time points. And we analyzed a total of, until now, well, the study is still ongoing, but we analyzed a total of 21 patients for germline and clonal hematopoiesis variant analysis. And the median age of the population was 59 years, and in the great majority of cases were treated with olaparib, and they were pre-treated with multiple cycle of platinum-based chemotherapy. So the germ variant analysis by Mielo panel consented the identification of 35 germline mutation in 21 ovarian cancer patients, and 31% of mutation are pathogenetic variants, and 50 found in 48% of the patients, and most of them were heterozygous mutation of BRCA1 and 2 genes. By the way, we also identify in 2 genes 2 new mutations, 2 new germline mutations, which were unknown before, and K2PG29 and SLC39A mutation. These are the germline mutation identified in each patient, included the pathogenic new germline mutations. So then we proceed in the same patient with clonal hematopoiesis panel that, as I said, it is more sensitive. It has got a high sensitivity. And with CHIP panel, we identified 224 clonal hematopoiesis mutation in 19 patients, and 55% of those mutations are clonal hematopoiesis driver mutation, so they can potentially trigger the leukemias. The most frequent mutation identified are TP53 mutation, DNMT3A mutation, which are also driver mutation, and PPM1D mutation, and then many others, but the most frequent one were those 3 mutations. Actually, all patients harbored clonal hematopoietic mutation before PARP inhibition, before starting PARP inhibitors, because of course they were pre-exposed to platinum. And moreover, each patient with clonal hematopoiesis mutation harbored at least 1 driver mutation, as you can see. But in more than, as you can see, in 4 patients, we didn't have both time points. So the pre-PARP inhibitors and after 6 months. But in more than 50% of the patients, the absolute number of mutation increased, even though this does not reach statistical significance. But it seems that so the absolute number of mutation actually increased, as you see in this histogram, even though until now the number of driver mutation is didn't change, but it's very early because it's only time point 6. And by contrast, if you're going to see the variant and length frequency of both single mutation and driver mutation, they seem to increase after 6 months therapy with PARP inhibitors. So actually PARP inhibitors determine a selection of the mutated clone, and the variant allele frequency seems to increase very early, after 6 months. Then we have seen that one of the most frequently mutated genes is PPM1D, which is a magnesium-dependent protein phosphatase. And actually, as you see in the panel downstairs, we identified 19 clonal hematopoiesis driver mutation in our patient. And each patient harbored more than 1 mutation of these PPM1D genes. So we wanted to understand which was the function of PPM1D, and this is a gene located at the 17q23 chromosomes band, and it codes serine threonine phosphatase that negatively regulates multiple components of DNA damage response, including the P53. And P53, it is active in its phosphorylated form. And PPM1D mutation consists of a C-terminal truncation, causes loss of degradation domain, resulting in an increased enzymatic function. And so this phosphatase inhibits p53 activity through dephosphorylation. So it has got a synergistic action with p53, inhibiting, inactivating p53 function and all function related to TP53. So we identified 19 driver chip mutation in PPM1D, and the number of mutation was similar, so it's too early to determine if the number of mutation increases after PARP inhibitor treatment, but the variant allele frequency distribution after 6 months already increased almost in all patients. So this is the clonal dynamics, and the take-home message is that even if each patient has got many PPM1D mutation, only some of them do increase during treatment. So only the PARP inhibitor pressure select only some mutated clone, not every clone. So in summary, can
السلايد اللي قبليه من فضلك.
Okay, anyway.
اللي قبليه.
So in summary, I will so in summary, among clonal hematopoietic mutation, 55% are driver mutation, and the most frequent mutated gene are TP53, the NMT3A, and PPM1D, also likely due to previous platinum-based chemotherapy. After 6 months of PARP inhibitor therapy, observe a similar absolute number of clonal hematopoiesis and driver variants, while their VAF seems to increase over time. And this is, and after 6 months of PARP inhibitor therapy, we scored an increase in BAF of at least one of the PPM1D mutation, 75% of patients analyzed. We couldn't be able to observe a correlation between PPM1D mutation and patient BRCA status, and longer follow-up are necessary to obtain a more precise picture of clonal dynamics in the subject analyzed and define a possible role of PARP inhibitor treatment in our clinical setting. So also Dr. Safar Ramadan participated to this study, of course. And thank you very much for your attention.
Thank you very much, Professor Elizabeth, for this wonderful delivery of secondary leukemias and the relation to PARP inhibitors. So if you can accept a couple of questions,
of course, please. Of course.
Dr. Rafat.
Of course, actually, I didn't talk about what we did in these 20 cases, but most of them were treated with Vyxeos. Do you know Vyxeos? I don't know if you have this drug here, but it is a new formulation of daunoblastin and Ara-C. It is a molar ratio of 5.1, and it is included in a liposome. So actually, it's much more. Even if it is old drug, they show in the phase 3 study, which was published a couple of years ago, first name Lancet. It was a randomized study 3-7 versus Vyxeos, and Vyxeos showed an higher incidence of complete remission and progression-free survival and overall survival also in elderly. And so it was registered in Italy for therapy-related leukemia and secondary to myelodysplastic syndrome. So actually, in most of those patients which had complex cytogenetic, we use Vyxeos. But if the patient the woman was very much pretreated or had comorbidity, we used Venazza. But unfortunately, because most of them are TP53 mutated, new data on venetoclax clearly show that venetoclax is not useful in this TP53 mutated patient. Anyway, after one chemotherapy cycle, Venazza or Vyxeos, when we had the possibility where they were fit for allogenic bone marrow transplantation, we transplanted them, and on 16 patients, only 3 are alive, but better than nothing, because it's an incurable disease. So actually, the aim of this study is to being able at a certain to prevent leukemia, and because PARP inhibitor is such a wide use drug also in breast cancer, for example, to try to study the genetic landscape of each woman when you have to start PARP inhibitor and see if there are triggering mutation, and say, okay, maybe in future there will be another drug for you, but it's not the case to take PARP inhibitors because you prolong your survival, but then you will get leukemia, because 10% incidence is very high. So what I suggest a very tight collaboration in cancer centers with between oncologists and hematologists in case of pancytopenia, in order to prevent the transformation of CCUS, of pre-leukemia to overt leukemia, because otherwise you have to try to cure with allogenic transplantation, which sometimes succeed, but most of the time not. It's a secondary. I think this is a secondary. I think this is a secondary disease, because actually maybe this is a field that should be studied. Because maybe there is a role of chemotherapy or radiotherapy for breast cancer, but so maybe there are some genes in clonal hematopoiesis that can also be triggering gene for myeloma or plasma cell dyscrasia, but we still don't know. We still don't know if these are two new tumors or one the consequence of the other.
Elizabeth, I just have one question, a quick question. You did the sequencing in double, so you took a germline tissue and the blood sample. I mean, you detected germline mutations and you detected acquired somatic mutation. So my question, did the presence of a germline mutation increase the risk of myelodysplastic syndrome in presence of acquisition of more clonal mutations from blood?
Yes. This is a very good way. This project, one of the main aim of this project, if it's to understand this. Until now, we haven't seen a correlation between a somatic mutation and a germline mutation, as we said, but we are sure that this correlation there is, because most of these women are germline mutated, they are BRCA mutated, more than 50% they are BRCA mutated, and for sure, so the BRCA gene is implicated in DNA repair. So of course, it is easy to think about the fact that BRCA mutated woman, that the germline mutation on BRCA gene is a predisposing factor to, but we weren't able until now to show that, but because it's too early, because as you see, we have only time point 6 months after treatment, but we are sure, but the study is going on. We are including much more patients, and we are analyzing later time points. And one of the aim is to demonstrate a linking between BRCA mutation or germ or other mutation hitting germline genes predisposing to cancer, solid cancer, and somatic mutation.
And your study applied to all kinds of PARP inhibitors, olaparib, to all kinds?
Yes, this is another important question. Actually, in this study are included women treated with every type of reimbursed PARP inhibitor, because now AstraZeneca it's also studying because it is of it's studying selective PARP inhibitor in order to avoid maybe adverse event.
Professor Elizabetta, I have a question. For the patient receiving PARP inhibitor as a management of recurrent ovarian cancer, at this situation we have a patient already with active recurrent ovarian cancer and she developed acute leukemia. What is the situation of therapy? We know that in that situation the patient may need chemotherapy for ovarian cancer, and at the same time we need to treat the therapy related. I think it's a very complicated situation.
It's a very usually all the patient we cured for acute leukemia, they were in CR for their ovarian cancer.
The adjuvant situation.
I didn't say that because I wanted to show you the scientific data of the project, so I didn't describe in detail the clinical course of leukemia patient, so I didn't say that. But the condition for performing a chemotherapy and allogeneic stem cell transplantation was that the metastatic cancer was in apparent remission. So apparent remission means a TC scan which was negative or RMRI negative. Of course, these are patients where for sure there is minimal residual disease that before and after they relapse. So actually it's not a deep or real remission, but at least radiological remission. So this was the condition to proceed with the intensive or intermediate intensive with Venasa, chemotherapy and allogeneic transplantation. Also because, of course, after allogeneic transplantation, you have more than 3 months of immunosuppression. So actually you reduce immunological defense, and this increase a lot the incidence of relapse also of the solid cancer. So to answer your question, if you have active ovarian cancer and leukemia, unfortunately, there's nothing to do for that patient, of course.
Thank you. Thanks for your elegant presentation and your interesting topic, and we hope to see you the next year, inshallah. Thanks.
Thank you very much.
Thank you. Thanks, Professor Safa, and we hope to see you next year, inshallah. Thanks. Now I have the honor to introduce Professor Ihab Hanafi, Professor of Anesthesia and ICU National Cancer Institute. He will talk to us about sepsis and septic shock management and new guidelines. Please, Professor Ihab.
Good morning, everybody. Actually, it's a great honor for me to be here between you and such eminent oncologist and hemato-oncologist. Why I'm here? This is an important question. Actually, I know that every topic here is discussing the cancers, hematological malignancies and how to treat and the recent updates. but we are commonly meeting a common thread which is already available in each word of your eminent daily presentations. This is infection, sepsis. And my role here is just to make such a red signal regarding such common threat and how to try treatment and to deal with such infections in the ICU. This is a common presentation on a daily basis. 64 male, hypertensive, diabetic, presented with a resection of colonic mass with colostomy 3 weeks ago. Patient is presented with fever, productive cough, shortness of breath, and the initial presentation is a common presentation. Patient with heart rate 162, respiratory rate 40, saturation 90, with all the septic markers going on. I'll go fast. What's the plan? The diagnosis and differential diagnosis, what we are thinking about the source of sepsis, and what are the fluids we have to start with, types, volumes, and lines, vasopressors, type and dose, antibiotics, antifungal, and cultures. What shall we start with, and what is the available antibiotics we are commonly dealing with? The airway management. Shall we give steroids from the beginning? And what about feeding? Is it enteral or parenteral? And what about the next step? So let's jump for the surviving sepsis campaign. What is the surviving sepsis campaign? Actually, this is the original documented source for the guidelines regarding sepsis and septic shock. The surviving sepsis campaign, it was launched in 2002 by a collaborative initiative of the European Society of Intensive Care Medicine and the International Sepsis Forum and the Society of Critical Care Medicine. Actually, the main objective was through the development and the promulgation of evidence-based guidelines and facilitating the application of knowledge derived from clinical trials and data at bedside tests. So the main hope was reduction of the mortality and the fatality regarding sepsis patient and preventing the progression of sepsis into the what's so-called septic shock, which is a common fright and the major lethal cause in the ICU. It developed some evidence-based management guidelines and undertook broad educational problems just to implement them and to force everybody all over the world to just apply such guidelines. It has an impact regarding the care of the septic shock patients and the catalyzed changes. So what is the original diagnosis of sepsis and septic shock was? Actually, in the past, in 2002, we have 4 main steps of the septic shock to develop. It starts with what's so-called SIRS, systemic inflammatory response syndrome, and it was diagnosed by infectious or non-infectious causes. It has some guidelines. I don't want to go to the depths, but actually it is the simplest form of sepsis. Patient usually presenting with tachycardia, with some fever, with some leukocytosis or leukopenia, and such patient we have such possibilities or what's so-called we are thinking about sepsis. The next step is sepsis, which is the SIRS criteria plus or added to presumed or confirmed source of infection. We have a documented source of infection. The next step is severe sepsis, which is sepsis plus what's so-called sepsis-induced organ failure and hypoperfusion. This is the hypotension that we are commonly seeing in such septic patient, a septic patient with a source of sepsis and decreased blood pressure. Lastly is the septic shock, which is the patient with a classic picture with the so-called multi-organ dysfunction syndrome and the affection of many systems. I'll go fast. This is the criteria of SIRS and how to diagnose it. We have 2 at least of the 4 criteria just to diagnose what's so-called SIRS. Later on, in 2016, that was another consensus of the surviving sepsis campaign just to re-evaluate the definitions, and they removed the SIRS. They said actually it's commonly seen in septic or non-septic patients. They reserved the sepsis and they removed the septic shock, the severe sepsis, because it's a transition and we don't have a sharp cut line between them, and lastly is a septic shock. So they replaced the SIRS by what's called Q-SOFA, the quick SOFA. What is the Q-SOFA? SOFA is a sequential organ failure scoring system. It's a complicated scoring system regarding all the patient's data, but the Q-SOFA is a very simplest form, which is 3 criteria. and they give some abbreviation about what's so-called HAT, hypotension, altered mental status, and the respiratory rate above 22. Any two of these three are documenting the original starting of the sepsis and septic shock. This is the how to evaluate or diagnose sepsis. Then later on, sepsis will proceed into severe sepsis or sepsis, then the septic shock with the classic picture of hypotension with a mean arterial blood pressure less than 65 and added to elevated or raised serum lactate level above 2 millimole per liter. Those are the common definition. Sepsis is a life-threatening organ dysfunction caused by dysregulated host response, and septic shock, as we said, the sepsis plus hypoperfusion and multi-organ dysfunction. Simply, in the ward or even when the patient is received by the emergency room department or in the ICU, we have to give 3 and take 3. Give oxygen to the patient just to keep the oxygen saturation around 94 to 98. Give some IV fluids, fast, rapid. It's around 30 ml per kg in the first hour, and we have some discussion regarding it later on. And the antimicrobial, we have to start the broad spectrum, double coverage antibiotics. And we have to take 3. What are the 3? Number 1, pan culture, culture density. Number 2, the blood, just to give the full blood survey, a full blood count. And lastly, the urine output calculation, which is usually in the septic shock patient less than what's called half milliliter per kg per hour. The key points in the management of septic shock or the sepsis are the fluids, source control, antibiotics, vasopressors plus or minus steroids, mechanical ventilation, nutrition, and lastly and not the least is the 2023 updates. I'll go fast. Surviving sepsis campaign protocols. We have in the past what's so-called protocol-based guidelines, and lately, I mean in the 2018 and 2020, it was shifted into the so-called early goal-directed protocol regarding the fluid therapy. We don't have to rush for protocolized algorithm. We don't have to keep the CVP, to give and wait, to give and wait. No, we have some goals to start with. We have the so-called IVC collapsibility, we have the straight regression test, and we have the vital signs document. This is the New England Journal, and it was launched in 2014 that concludes in the multicentric trial conducted in tertiary care centers that the protocol-based resuscitation didn't improve the outcome, and they enforce it and push for the goal-directed protocol. This is some examples for the protocol which has been used in the California or Irvine or Minnesota. Those are some protocolized protocol. Nowadays, we are following the so-called early goal-directed therapy, and we have some definitions that we have to follow. CVP around 8 to 12 millimeter mercury, mean arterial blood pressure above 65, urine output above half milliliter per kg per hour, and the mixed venous oxygen saturation should be kept above 65%. This is a systematic review and meta-analysis comparing the goal-directed and the protocolized, and as we said, the goal-directed therapy is the first and has to be followed nowadays in the resuscitation. The initial resuscitation with a strong recommendation and low quality of evidence was to start with 30 ml per kg per hour, crystalloids. We don't have to give any colloids because we usually see in the ward sessions, they are giving the so-called albumin or colloids to raise the blood pressure, which is not nowadays documented. Following the initial resuscitation, we have to frequently reassess the hemodynamics regarding urine output, CVP, and we said the blood pressure. 2023 updates was the total amount of fluid. It's not mandatory to keep such volume of IV fluid resuscitation. We commonly hear about give only 1.5 to 2 liters in the first hour, or start with half liter per hour and keep it maximally to 5 liters per hour. It's not nowadays recommended to give so. We have the so-called fluid tolerance and the fluid responsiveness. I'll not go deep through that because it's a little bit sophisticated, but usually we are giving firstly the 200 to 500 milliliters, just to check the response of the patient and to monitor whether the patient is a fluid responder patient or non-fluid responder patient. The fluid therapy, as we said, crystalloids is the fluid of choice. the normal saline, the lactated ringer, or the acetated ringer. The albumin is nowadays reserved such for the earlier irresponsive patients and as a second or final step and with a weak recommendation and low quality of evidence. Sepsis and septic shock are medical emergencies that needs to immediate start of treatment and resuscitation efforts. Don't forget the source control. Source control is one of the clue rule. We don't have any role in the management of sepsis and septic shock without source control. We don't have to lose effort in giving fluids, antibiotics, give such cultures in the sensitivity, measuring the PCT, procalcitonin, measuring the lactate level, and finally we found the patient is having a source control, a source which is not controlled yet. For example, intra-abdominal sepsis, abscess, infected bed sores, and so on. The diagnosis, depending mainly on culture and sensitivity, appropriate routine microbiological culture, including blood, should be obtained before starting antimicrobial therapy. The empiric antibiotic start is a mandatory and the clue rule in the management, so we have to follow it. The empiric therapy followed by the culture-based, whether escalating the antibiotic type or de-escalating the antibiotic type. This is cards which are usually distributed by the Surviving Sepsis Campaign for every ICU and for every ward patients. Number one, it's so-called the first hour bundle protocol, initial resuscitation for sepsis and septic shock. Number one, measure lactate level, just to know where we are. Number two, obtaining blood culture before administering antibiotics. Administer early administration of broad spectrum antibiotics, begin rapid administration of 30 ml per kg crystalloids, and if hypotension is persisting, we have to repeat the 30 ml per kg. Then lastly and not the least, to start with the vasopressors to maintain organ perfusion. Again, this is another card regarding a quick response for sepsis and septic shock recognition and monitoring closely for the intervention and whether we have a further intervention to be done or not. Usually those are some cards distributed by the Surviving Sepsis Campaign and approved by all the hospitals, and they have to be implemented in all ICUs or even wards. It's like a sticky cards to be given for every medical personnel in the ward. When to give or when to start the antibiotics, this is a question. As early as possible, whether the patient has a definite source of sepsis or we are suspecting by the QSOFA that the patient is having suspected sepsis, we have to start the antibiotic as early as possible, even before obtaining the blood culture and sensitivity. The vasoactive agent, I mean the vasopressors like noradrenaline or vasopressin, when to give it. In case of suspicion of sepsis or septic shock, we have to start it as early as possible. In case we don't have a definite source, we have to correct, then to start with vasopressors. We don't start vasopressors from the beginning, from day zero. We don't have to start with vasopressors without defining the cause of sepsis, because in many conditions we have an interlacing or different types of shock, like hypovolemic shock, like the cardiogenic shock, like the septic shock, of course. So we have to differentiate between each one of them before starting the vasopressor administration. Antibiotics, what to give? In the past, I mean 2016, the Surviving Sepsis Campaign 2 were recommending only one antibiotic, broad spectrum antibiotic, of course covering most of the gram-negative, gram-positive and anaerobes to start with. Lately, I mean in 2019, they have upgraded the antibiotic protocol to be started with as an empirical treatment. We have to start with dual anti-pseudomonal coverage, 2 antibiotics, one of them at least have an anti-pseudomonal coverage. And this was widely accepted and documented in 2023 by the revised protocol of the Surviving Sepsis Campaign. This is, as we said, combination therapy were not routinely used in 2017 and again in 2023 were re-implemented again. What are the empiric antibiotic therapy should be started with? I said that we have to start with a powerful anti-gram negative, powerful anti-gram positive, and anti-anaerobic. Of course, in hematological emergencies, I mean in suspicion of sepsis in such immunodepleted patient, fever neutropenic patients, we have to add on an antifungal and antiviral as an empiric therapy from the beginning. Number two, which is my message today, don't forget to give a wide spectrum antibiotic, but with a less burden on the kidneys and the liver. We are not treating a source of infection with deterioration of other organs, which are usually preserved till a certain point in septic shock patient, then they will start a multi-organ infection. Again, what is the target blood pressure that we have to keep it on? It's a mean blood pressure around 65. This is an interesting, actually, paper that was launched in the New England Journal of Medicine, and with a strong recommendation and moderate quality evidence, it compares between a high and low blood pressure target in septic shock patient. I mean, if you are giving fluid and vasopressors to keep mean arterial blood pressure around, for example, 65, which is the documented. Why not to keep it around 85, 90, 95? Why not? Would the patient benefit? That paper documented that on the 6 months, 1 month first and 6 months later on after surviving sepsis and septic shock patients, that the morbidity and the crude mortality rate didn't differ between 65 arm group and the 85 arm group. Moreover, some of the patients with a high blood pressure perfusion gain some disadvantages of the high vasopressor, long-term vasopressor. The ICU length of stay, the total hospital length of stay has been prolonged in such patients. The vasoactive agents, everybody knows that we are starting by noradrenaline, norepinephrine. Then if we fail to maintain the target blood pressure, we have to add on vasopressor or another adrenaline vasopressor. If the shock is not resolving quickly, we have to think about mixed types of shocks. Do we have to measure lactate level? Yes. Do we have to measure the PCT, procalcitonin? Yes. Actually, in the procalcitonin nowadays, we are measuring the procalcitonin as a prognostic marker. Is it less than 0.5 nanogram per milliliter? Is it between 0.5 to 2, above 2 or above 10? Of course, the least prognosis is above 10 patients. Start with an early source control, IV fluid and antibiotic, and don't miss that the patient may need corticosteroid if failed to maintain blood pressure with a high fluid therapy and antibiotic, and the blood pressure is still persistently low. We have to add the septic dose or the so-called stress dose of hydrocortisone, which is the 50 milligram every 6 hours. Methylprednisolone only in case of ARDS. Don't start with methylprednisolone from the beginning. Mechanical ventilation, different modes. Simplest form is the oxygen mask, and the advanced one is the non-invasive or even invasive mechanical ventilation, and different types has been documented to have some beneficial role. Don't use the so-called high-frequency oscillation ventilation in such patient. The glycemic control is very important. Renal replacement therapy in such patient with acute kidney injury, if they reach that point, it's very mandating. Lastly, and not the least, we'll talk about the nutrition, and that will take 1.5 minutes, the last 1.5 minutes. Actually, in the past, they were against the enteral feeding, the early enteral feeding. Don't start enteral feeding in shocked patients. Actually, they have a stomach hypoperfused. The blood perfusion is distributed mainly for the vital organ, like the coronaries, the brain, and so on. So don't start with a heavy load of enteral feeding. Nowadays, they have released two biggest trials. It was a multicentric French trial. Another one, it was a Japanese trial. They compared between the early and the late enteral feeding, and they have found that the early enteral feeding in low and mid vasopressor infusion rate, actually it was beneficial for such patients. What type of enteral feeding we have to give? Actually, they reinforced the so-called the trophic feeding, which is the hypocaloric feeding. Don't give a full calorie or a full enteral support for such patients, because usually they will have a so-called refeeding syndrome, or the stress ulcer perforation and the peptic ulceration is of a high prevalence rate for such patients. Thank you very much.
Thank you very much, Professor Ihab, about this wonderful delivery about recent guidelines of sepsis, septic shock. If you can accept a question, Professor Ihab. Dr. Rafat, a question for Professor Ihab, BMT patients and sepsis or septic shock. Do you have a question? اوكي طيب دكتور ايهاب هسألك سؤال بالنسبة للعيانين اللي بيخشوا في شوك حضرتك على ما الكالتشرز بتطلع بتاخد يعني couple of days أو maybe more. Do you have during this time إنك تعمل الورك اب بتاعك علشان تشوف السبسس ده أو سوري الشوك ده is it a septic shock or another type of shock يعني during this period لحد ما الكالتشرز تطلع يعني.
Actually, we have a protocolized way. I said that we are starting with the source control, number one. Number two, the high probability. Do we have a high probability index or low probability index? If you have a documented, for example, CT chest showing infiltrates in the, or we have some pus cells, heavy colonization in the urine analysis, for example. This is a rapid evaluation, I mean. So we have to start with fluid resuscitation. We have to start with broad spectrum antibiotic, empiric therapy, as we said, double anti-pseudomonal coverage. And we have to take blood cultures, and pan culture, of course, and we have to send it as early as possible. Within a couple of days, actually, we don't have a full signal. I mean, the full culture and sensitivity result. But at least we have starting signal. Usually the lab or the clinical microbiology lab, they are giving us some feedbacks. I have some signal which is justifying the gram-negative septicemia. I have some signals showing that we have bed sores, and that bed sores showing high probability of gram-positive infection. So we are on the right track. But if we are during this time, we have, I don't have to put it sophisticated, but usually we do a bedside echo, for example, and we are measuring the so-called pulmonary capillary wedge pressure. If we found it high, pulmonary capillary wedge pressure, and the patient showing wall motion abnormalities justifying or giving some suspicions that the patient is having acute myocardial infarction. So it's a combined type of shock, or it's an isolated cardiogenic shock rather than septic shock. So we have to be directed to that point, because for example, the last week we found that the patient has been treated for 3 days as if he septic shock, but we have some suspicions that the patient is having some showering pulmonary embolism. When we did IVC collapsibility and the echocardiography, we found right ventricular stream pattern and the tricuspid regurg. We sent the patient for CT pulmonary angio when we stabilized him and resuscitated, and we found the patient already is having pulmonary embolism. That means the shock was an obstructive shock rather than septic shock, another type of shock and another type of management protocols.
Very good. Thank you very much, Professor, for your time and for the wonderful delivery. Now I'm honored to introduce my friend and colleague, Professor Dr. Rafat Abdel Fattah. He will talk to us about the autologous marrow transplantation in multiple myeloma. Professor Rafat is a professor at the National Cancer Institute of Hematology and Bone Marrow Transplant. He is also the director and manager of the National Cancer Institute. Professor Rafat.
Good evening, all of you. I will speak about transplantation in multiple myeloma. I will answer mainly 2 questions. When you transplant and how you transplant patient. At the timing of transplant may be early after inductions of remissions and may be late after the relapse of the patient. But the overall survival, 5 years, there is no difference between early transplant or late transplant. It is a 63% versus 63%. The median overall survival is for early transplant not reached versus 75 months for late transplant, but statistically there is no difference. Also, the median progression-free survival, there is a difference. It's 28 months versus 18 months for late transplant, but statistically not different. But what about the high-risk patients? This is the difference between the progression-free survival is 25 months for patient with early transplant versus only 11 months for patient with late transplant, and so the guideline speak now all patient is preferred to be early transplant. The objective today is to how to pre-transplant assessment, how to select criteria for your patient, and what is the mobilization regimen and the conditioning regimen, stem cell source, and how many types of transplant. The pre-transplant, you should assess the patient for any clinical issue about kidney, lung, heart, and performance status. The kidney, not in all, if you have a patient with renal failure due to disease, you can go for transplant and you're having a chance to reverse the kidney to be not for dialysis. But if they're having a patient who's already chronically renal failures for many years and achieve having multiple myeloma, this is an issue. It's difficult to be transplanted because usually this patient is not fit for transplant. So who is the transplant eligible and who is the transplant non-eligible? The transplant eligible patients, the age is less than 70 years, performance status 0 to 1, organ function adequate, significant comorbidity absent, and the goal of therapy usually to cure the patient or to having a very good progression-free survival and overall survival. This is the result for autologous stem cell transplant in the aging of the patient, less than 70 years of old and more than 70 years of age. As you see, there is no difference. Still, some centers now transplant patient up to 75 years old because high dose therapy is feasible in a selected patient with myeloma over than 70 years old. Likely that the older patient were selected based on their performance status, factor difficult to be analyzed in a retrospective review. Nearly 70% of the early patient can receive full doses melphalan as a conditioning regimen to 100 patients, and the other patient can receiving melphalan with about 140. It's usually it's having a myeloablative dose and can be having a very good for transplant patient. The toxicity of transplant as well. The outcome appears similar to younger patients. Patients with myeloma should not be excluding for high-dose therapy on a basis of their chronological age. But you can see your patient. If you're having the patient is a very good performance season and you see us in a good shape, you can go for transplant. Don't see that the patient is 70, 75. No, you can transplant even up to 75 patients. According to the mobilization, you can use growth factor plus chemotherapy, and or using homozipil, which is Belarix4. And what is the difference? Growth factors, it is a cost effectiveness. You having the patient only 4 days, growth factor subcutaneous, and the 5 days you can collect the stem cell. Successful mobilization in myeloma patient in a most patient, predicted schedule, because as I said, 4 days and the 5th day you would select. But what is the disadvantage? No anti-myeloma effects, the growth factor, no high chemotherapeutic effect, multiple injection and collection, potential suboptimal yielding, usually can select only 2 million cells. What about the chemotherapy? Chemotherapy is having anti-myeloma effect, increasing the yield of the cells, and also only one apheresis can be sufficient. But we're having some sort of cytopenias, which might lead to infection and potential transfusion requirement for platelets and blood. About the mozapil, usually the mozapil can be used in a patient failed GCSF, not usually as a standard of treatment, and it is cost. So the recommendation that you can usually all patients with GCSF, because this is limit use to the patient, never exposed to melphalan or any chemotherapeutic agent. As I said, for usually the patient not needed to be received more than 4 cycles of lenalidomide, because if your patient having more than 4 cycles of lenalidomide, usually mobilization with GCSF will not be enough. The usual dose is 10 to 16 microgram per kg. This is a very important issue because most of us using only one ampoule. One ampoule means was 300 microgram, but the dose is from 10 to 16 microgram per kg. Can be used once or can be used twice every 12 hours. About the chemotherapeutic agents, this is limited for patients who is not having adequately respond to salvage therapy. Here, your patient having a partial response, and you need to more response. You can start with high dose cyclophosphamide. High dose cyclophosphamide can controlling the myeloma, and also you can collect the stem cell for it. About Plerixafor, as I said before, you can use only in a failures of collections with others. And what about the patient? Bone marrow harvest or peripheral blood stem cell? All centers worldwide using peripheral blood stem cell and myeloma because usually bone marrow is not good for myeloma patient because usually bone marrow are having still a plasma cell. The other cell, how to condition? What is the condition? How you transplant patient with myeloma? Auto transplant using high dose chemotherapy to control the disease, to decrease the minimum residual disease, to prevent relapse, and to having a very good progression-free survival, and to maybe having a good overall survival. You need high dose chemotherapy will destroy the bone marrow, so you collect the stem cell to be rescue for the patient. This the condition. So you give before giving the condition, you mobilize and collecting the cell. The condition regimen usually melphalan 200 milligram divided into days usually, or can be given once. Many studies having melphalan with total body irradiations, decreasing the dose of melphalan to 140 and increasing, adding TBI, and another study using the bendamustins with cyclophosphamide and the beam regimen which used in diffuse large B-cell lymphoma and other lymphoma subtypes, but the standard of care from these trials is still the melphalan 200 milligram. This is an IV regimen, not oral treatment. What about the stem cell source? As I said before, peripheral blood stem cell, not the bone marrow. For how many? You're collecting usually, as I said before, the standard of care is one transplant, and I will see why now. Single versus double transplant. Single versus double for newly diagnosed myeloma patient is still debate from about 13 years from auto transplant for myeloma starting from 1988 and until now is still having a debate. So before the era of the novel agent like daratumumab, bispecific therapy, carfilzomib, double transplant conferred longer overall survival and or progression-free survival and improved outcome for patient failing to achieve very good partial response after stem cell transplant. But after the era of novel agent, benefit of double transplant or tandem transplant restricted to patients with translocation 414 or deletion 17B, which is a very high risk myeloma patient. It depends like guideline recommended consideration of double stem cell or tandem transplant for the patient with a high risk cytogenetic or those who don't achieve very good partial response and at first remission. Current analysis prospectively assesses efficacy of a single versus standard transplant in a patient with newly diagnosed myeloma from two studies. As you said, this is the first trials. This is the stamina trials, which comparing single transplant versus tandem transplant versus no transplant, and to continue for about 28 cycle for VRT to continue cycles without transplantation. No, sorry, this is another study. This is study stamina trial comparing the high VRT followed by transplant, followed by one transplant, followed by another transplant, or keeping with single transplant. As you see from the trials, there is no difference between the progression-free survival or overall survival for patients receiving single versus tandem transplant. But tandem versus single is the same trial. This is published by Cabo about 10 years ago. As you see, there is no the difference between the patient having harboring the deletion 17B or translocation 414. It is highly significant for the overall survival for tandem transplant. It's about 76% versus 33% only, and the 5-year progression-free survival on the same patient is about 53.5 versus 44.9, and when collecting the old patient, having an overall survival for the patient 83.3 versus 72.6% for the all patient low risk, high risk, and harboring the high risk cytogenetic. But I said this is before the era of new drugs and bispecific therapy. So the summary for initial treatment of for younger patient of 3 or drug induction regimen VRD, KRD, or now you can add in daratumumab. Autologous stem cell transplant for all patients. Don't need for any age you can transplant. Maintenance lenalidomide, and maybe if your patient high risk or having a kidney problem, you can use bortezomib inhibitor. So the induction treatment for transplant in eligible patient before transplant, usually using the three drug regimen due to the SWAP trials, which published about 6 years ago, which comparing 2 drug versus 3, lenalidomide dexa versus bortezomib lenalidomide dexa. At this time, the dexamethasone is a backbone for treatment of autologous stem cell transplant, and adding now the lenalidomide, another backbone. When adding bortezomib for this patient, you see that overall response rate is about 80% for patients with VRD versus 72% for the doublet drugs is RD, and the overall survival is 75 versus 64. Only trials comparing the VTT regimen, which usually used in Europe, and versus the VCT, which is the preferred regimen in Egypt because it is the low toxicity and we don't have thalidomide at this time. But the data from comparing from the IFM trial, the phase 3 trial comparing, the very good partial response rate is 66% versus VCD is about 56%, and this is significant. And also the PR rate is higher for the VTD versus VCD, and also the CR rate is 13% versus 8.9. But as you see, there is no statistical difference in CR patient. So until now, we can using the VCD regimen, but the VTT regimen is less toxic on the bone marrow. What about the new drugs, the 4 drug regimen, the comparing induction pre-transplant by daratumumab with the VTT? As I said before, VTT is the preferred treatment in Europe. Adding the daratumumab followed by transplant and followed by consolidation of 2 cycles, followed by maintenance daratumumab versus observation. From this study, you see that adding daratumumab to the VTT superior across all subgroups, including the high risk cytogenetic according to the international scaling system stage 3 patient, and also 53% reduction in the risk of progression or death in the DVT arms. The another trial, this is the United States or American trials, usually using the RVD, not the thalidomide, comparing the VRD plus daratumumab versus VRD alone, and also the response rate and depths were greater for the daratumumab arm, and also the MRD negativity for the daratumumab arm still, and still all the patient going for early transplant. So the estimated progression-free survival and overall survival after 2 years for this arm is about more than 99%, but the impressive result also achieved in the VRD arm. We're having a very good, after 2 years, a very good overall survival rate. So the combination therapy of patient with newly diagnosed transplant patient from the old trials to adding, you can adding now for a high risk patient, carfilzomib is having a very good result for the high risk patient as a first line, daratumumab with VTT, daratumumab with VRD still having, and all of this also go for transplant. What about the maintenance? The standard of treatment of the lenalidomide 10 milligram continuous, not 21 days. You can go for continuous. But if your patient having a peripheral neuropathy and complication, you can 21 days and stop for 7 days. This having a result of 62% of all survivors after 7 years versus 50%. This is the first trial to achieve that. The maintenance lenalidomide is having a very good result about the overall survival for myeloma patient. And also, as I said before, if your patient is a high-risk patient by cytogenetics or having a kidney problem, you can having the subcutaneous bortezomib every 2 weeks for 1 to 2 years or until disease progression. So, the summary for currently available treatment option for newly diagnosed transplant-eligible myeloma patient, induction, VRT still the preferred regimen. TRT for high-risk patient, promising data about adding daratumumab for the VRT. Autologous stem cell consultation for all patients. Maintenance lenalidomide is still the standard of care. Consider clinical trials if you're having in Egypt. So the eligibility for autologous stem cell transplant of your patient, yes, from the start, go for VTD plus or minus, or VRD plus or minus the daratumumab, followed by transplant with melphalan 200 milligram, followed by stem cell transplant for all patient, maintenance with lenalidomide, and now there is a trial for istoximab Nilaro with Darzalex as a maintenance with a very good promising result. Thank you for your attention.
Thanks, Professor Rafat, for your elegant presentation, and we can accept one or two questions if we have. For me, I have a question for the patient who received tandem transplant. You mentioned that those with deletion 17p achieved a good overall survival response. For whom else you may accept the second transplant?
First of all, I don't do tandem transplant. And now, worldwide, there is no tandem transplant. If your patient is a high risk, if your patient is having a regular disease, you can add one new drugs and daratumumab, but usually it is not used. If you can use, you can go for bispecific therapy, and as you see from the protocol, bispecific therapy not contraindicated with the stem cell transplant. You can use new drugs and add a more deep response for transplant, so you don't need for second transplant. But if you ask me about second transplant after more than 2 years or 3 years, accept it now for Minister of Health, but this week. We're having a new food for patients who have autologous transplant, relapsed by more than 3 years, you go for
another one. Yes, yes. This long disease-free interval we can accept. Yes. That's it. Okay. Thanks, Professor Rafat. You have another question to answer?
The fastest time to decide a transplant in a myeloma patient, is it بعد 4 cycles ممكن to 4 cycles?
Usually, I look for evaluation of the patient after 2 cycles to see if my patient is in a responding or not. Evaluate after 2 cycles and continue for the 4th cycle. And usually this is the maximum usually for lenalidomide. If your patient is not responding very good for very good partial response and you don't can be transferred to transplant, stop lenalidomide and add another drug to go for more deep response.
والمينتنس after transplant انا شايف
lenalidomide 2 years. Usually we call lenalidomide until disease progression, but as I know right now is 2 years is enough because we're having a very bad news about the secondary malignancy for lenalidomide.
بيبتدي من امتى بعد الترانسبلانت؟
Usually about starting complete hematological recovery, usually standard of care about 42 days from day 0 of transplant, but for me usually something after 2 months.
2 months. Okay.
Practical situation, Dr. Rafat, the patient who end induction treatment and in the waiting list for the transplant, we may have several months waiting. What can we do in this period?
I prefer to use subcutaneous bortezomib every 2 weeks until transplant. Don't use lenalidomide until this. Okay? Thank you.
Thanks, Professor Rafat, and thanks for accepting the invitation. And now we will move to the second presentation by Professor Muhammad Amouti, the Dean of the National Cancer Institute. Please, Dr. Muhammad, he will talk to us about the frontline treatment in multiple myeloma, and thanks for accepting the invitation in your heavy duty.
شكرا دكتور حسين. هو طبعا انا كان نفسي طبعا انا يعني theoretical speaking كان المفروض اتكلم قبل رفعت يعني، بس يعني هو رفعت ريحني من حاجات كتير اقولها يعني. Multiple myeloma, as known, is a neoplastic plasma cell disorder with clonal proliferation of malignant plasma cells in the bone marrow microenvironment with the presence of monoclonal protein, or what's called M protein, in the blood or urine, associated with organ dysfunction and advanced disease. The pathogenesis relies on three factors, either the accumulation of monoclonal protein or marrow infiltration or immune deficiency. Accumulation of monoclonal protein lead to renal failure in quarter of patients, or hyperviscosity and amyloidosis in rare percentage of patients. Marrow infiltration is more important and lead to anemia in most of patients and release of cytokines leading to bone destruction, bone pains, pathologic fractures, osteopenia, and hypercalcemia. Also, there is a variety of symptoms and signs in myeloma, ranging from bone pains, especially in the back, spinal cord compression leading to weakness, sensory disturbance, and spheric dysfunction. And pathologic fracture is very common in myeloma, renal impairment, hypercalcemia with its different manifestation, and anemia in almost all patients. Many methods are used to diagnose and follow up myeloma. First of all, bone marrow aspirate and biopsy, serum protein analysis in either by electrophoresis, immune fixation, free light chain estimation, and diagnostic imaging, especially starting from skeletal survey, CT imaging, PET CT imaging, or whole body MRI imaging. Also, we have to characterize different high-risk cytogenetic abnormalities in myeloma, like transcription 414, 1416, and deletion 17B as considered a high-risk patient. But remember, to do a cytogenetic analysis in myeloma, you have to do it on assorted marrow, with especially in the CD138 positive cells only. To diagnose myeloma, you have to see any serum protein or urine protein in 24-hour urinary protein with bone marrow plasma cells more than 10, or biopsy proving bony or extramedullary cytoma, and most important, with one or more of slim crab features. Slim crab feature may be myeloma defining agents or slim or crab features. Slim features include 60% or more clonal plasma cell bone marrow, involved to non-involved free light chain ratio more than 100, and MRI imaging with one or more focal lesions, each more than 5 millimeters in size. The crab criteria all of us knows: hypercalcemia, renal impairment, anemia, and bone disease. Also, different factors are used for prognostic evaluate the patient with myeloma, especially with starting with ISS stage, relying only beta-2 microglobin and albumin level. More recently, standard high-risk cytogenetics and higher LDH levels are considered as a poor prognostic factors in what's called revised international scoring system for myeloma. The most important factor in evaluating the response of different treatment in myeloma is to assess the response. Response range from stringent CR with everything is negative, merging into complete response, the same with abnormal serum free light chain ratio, very good partial response with 90% reduction in serum protein and plasma cells less than 5%. And the aim of our treatment is to have, in general, very good partial response or more after induction treatment. Also, very recently, minimal residual disease have been evaluated as a response criteria for myeloma, as it's defined as low levels of disease that is detected only by laboratory techniques more sensitive than morphology, such as multiparametric flow cytometry or PCR estimation. And many pathways to get the deeper response to achieve deep or MRD negative status by using multi-drug regimen, autologous stem cell transplant, or lignal type therapy. And the range of treatment and range of disease is ranging from presentation, partial response, very good partial response, stringent CR, MRD, and hopefully the undetectable MRD, or what's called operational cure. And in different studies and a meta-analysis of studies published between 1990 and 2016 for eligible patients with MRD status and survival outcome in studies with 20 or more patients following therapy, and the results were reported in patients who achieved a conventional CR plus MRD negativity, and many evidence suggests that MRD negativity may be associated with longer overall survival and progressive survival in patients with newly diagnosed multiple myeloma who achieved a CR. So we have to remember that myeloma is incurable disease. It cannot be cured. The goal of treatment is to reduce symptoms, slow the progression of disease or advancement of disease, and put the disease into remission, as most of all signs of all signs of symptoms of disease disappear, and the progression of remission period was proven to impact disease trajectory. MRD negativity or deep response result in better BFS and sometimes overall survival. So before starting treatment, you have to define is your patient is eligible or candidate for transplant or not. To be eligible for transplant, as mentioned by Professor Rafat, it should be aged less than 70, but with a good performance status, organ dysfunction, knowing that advanced age alone and renal dysfunction alone is not a contraindication to transplant, with absence of few significant comorbidities, and the goal of treatment is these patients curative. We have many new treatment developed in myeloma therapy. We have 5 main types of proteasome inhibitors identified as proteasome inhibitors. Some of them are reversible, like proteasome ixazomib, and the others are irreversible, like carfilzomib. And proteasome inhibitors in general can bind either irreversibly or reversibly to the active enzyme sites of 20S proteasomes. Proteasomes is responsible about the destruction of anti-apoptotic proteins in the cells. Also, we have many IMID or immunomodulatory agents, starting with thalidomide, giving once daily, as mentioned by Professor Rafat. And the main toxicity is neuropathy, constipation, sedation, and of course DVT, and the patient should be anticoagulation. More recently, lenalidomide has been developed with the spectrum or pendulum toxicity moved into myelosuppression, skin rash, and also DVT. And more recently, pomalidomide is given as a daily dose with less constipation and neuropathy than thalidomide, less myelosuppressive than lenalidomide. Both of the 3 drugs are structurally similar but functionally different, both qualitatively and quantitatively. Also, the anti-CD38 molecular antibodies, which is a marker present in almost all malignant plasma cells, are developed. We have fully immunized anti-CD38 molecular antibodies, which are daratumumab or MOR 202, or what's called more recently velzaratinib, and we have a chimeric molecular antibodies, which is isatuximab. Many of them are working with antibody-dependent cellular cytotoxicity and antibody-dependent cellular phagocytosis, complement-dependent cytotoxicity, and inhibition of CD38 ectoenzyme activity, and lastly, direct cellular apoptosis acting on malignant cells. For the first line for transplant ineligible patient, I will stress here on transplant ineligible patient, as eligible patient was discussed thoroughly with Professor Rafat. For ineligible patient, it's proved that in the first trial, RD are better than MBT, which was a standard care at that time, melphalan, prednisone, thalidomide. Lenalidomide, dexamethasone was better, producing better BFS and better MBT. Also, in eligible patient, MVB, which is melphalan, Velcade, prednisone, was considered to better than MB according to first trial, and producing a better overall response rate and better CR rates, and of course better BFS and overall survival. In transplant eligible patients, the story is much different. 20 years ago, it was proving, according to the IFM trial, that VD is better than VAD, which is vancomycin, erythromycin, dexamethasone, producing a better CR, better very good partial response. And hematologic toxicity and disease-related toxicity were more frequent with VAD. On the other hand, rates of grade 2 and grade 3 to 3 to 4 peripheral were significantly higher with VD. And a trend to better, longer BFS, and however, in the overall survival was similar between both arms. And at that time, VD was considered as standard of care for eligible patients. Why not to add something to VD? We add thalidomide in 3 trials In 3 trials, VTD was compared to VD, and it led to higher response rate after induction and a greater CR and very good response rate after high dose therapy. However, no difference in BFS overall survival. And according to Jemima trial, VTD was compared to TD, and it produced better BFS and overall survival. And as previously mentioned by Professor Rafat, when VCD was compared to VCD, VTD is significantly superior to VCD in terms of very good partial response and response rate. However, neutropenia was more frequent with VCD, and neither BFS or survival data were collected in this study. Again, VRD merged to be the standard of care in patients with transplant ineligible patient according to SWOG S0777 trial. When compared to RD, it lead to better cumulative best response as a complete response, very good partial response or more, and overall response rate, and better response rate in general, and better BFS, better median overall survival, response duration, and 5 years overall survival. And VRD was considered now as one of the most effective standard of care in management of myeloma, either transplant eligible and transplant ineligible again, as we will see. So, we are convinced with a conventional standard of care till 5 years ago. Ineligible patient RD is better, MVP is a substitute. Frontline treatment with transplant ineligible patient, VTD and VRD can be used. VTD is used more commonly in Europe. VRD is used more commonly in USA. Why not to add daratumumab? According to the Maya trial, Dara was RD, and Allison trial, Dara was added to VMB, and the Casubea trial, Dara was added to VTD, and the Engraven trial, Dara was added to VRD. Moving very fast to this is the results of these studies. According to the Maya trial, when we compare Dara RD to RD, it led to in transplant ineligible patient. We can see that addition of Dara lead to BFS difference, and Dara demonstrate a significant BFS benefit with a median BFS not reached in Dara RD arm, 52% versus 28%. And more importantly, Dara RD reduced deeper response, better overall response rate, and better higher rates of CR or more, and with a 28 months of additional follow-up, response was deepened with continued with Dara therapy. And again, of course, MRD negativity rate and sustained MRD negativity rate was maintained in patient receiving Dara, with the MRD negativity rate 10-fold higher in the Dara RD group. And for the first time, an overall survival benefit of Dara-based regimen was seen in newly diagnosed patient, and the overall survival with Dara arm was 66, and the without Dara is 53%, and p-value was highly significant. And the benefit was with addition of 32% reduction in the risk of death in patients with newly diagnosed myeloma who are transplant ineligible receiving daratumumab. And in Allison trial, in transplant ineligible patient, Dara was added to VMB versus VMB alone, and we can see the BFS benefit was shown in the patient receiving daratumumab, and in the overall survival patient benefit leading to 36 reduction in the risk of death was observed with the addition of daratumumab. And again, the MRD negativity was higher, and overall survival was better in MRD negative status, both in Dara VMB arm and in VMB arm alone. And with the deepening of response is deepening with post-condition therapy. We can see the rates of single CR and complete CR was better in Dara VTD arm. And MRD negativity in Casubea trial, as mentioned by Professor Rafat, the post-condition MRD negative rates were significantly higher for Dara VTD versus VTD alone, confirming post-induction MRD negative rates. And again, a 53% reduction in the risk of progression of death with Dara VTD arm, and the incidence of having a CR or more MRD plus MRD negative was better, 33 versus 19%, and the BFS benefit Dara VTD versus VTD patient achieving MRD negativity plus CR or more. And also in the Cassiopeia trial, DARA maintenance in the part 2 of the study significantly improved BFS from second randomization versus observation in both arms. So adding DARA to standard of care, DARA RD is better than RD according to the Maya trial. The adding DARA to VMB is better than VMB alone according to the Assun trial. And on the other hand, transplant eligible patient adding DARA to VDD is better than VDD alone according to Cassiopeia trial. This changed the face of all myeloma guidelines all over the world. In the European side of the Atlantic, in transplant eligible patient, DARA VTD is more effective than VTD with a category 1A, but comparison are lacking versus DARA VRD or VRD. VRD is likely to offer the best risk-benefit profile to date among triplet combination. Either to use DARA VTD or to use VRD. VRD is accepted. On the other hand, in transplant eligible patient, we have 3 standard of care: VRD, DARA VMB, and DARA RD. When DARA RD or DARA VMB is not available, VRD is preferred if the patient is fit, and DARA and RD or VMB may be considered for patient who is frail or cannot receive the previous regimens. According to the most recent guidelines for newly diagnosed myeloma, for transplant candidate, VRD is category 1, KRD is a substitute. Other recommendation is DARA VRD. We can use VCD in renal impairment. We can use KCD in renal impairment peripheral neuritis. In transplant non-eligible patient, VRD is also category 1. DARA RD is category 1 as in preferred, and we can use other regimen in patients with certain circumstances. Maintenance is proved to be category 1 in both transplant candidate and non-candidate, and bortezomib can be used as mentioned by Professor Rafat in patients with renal impairment, and both of them are used simultaneously as DARA to Velcade or plus lenalidomide in patients having deletion 17B disease. So my first take-home message that three-drug regimen as a standard of care primary treatment of all transplant eligible patients, for example VRD, leading to improved response rate, depths of response, and BFS and overall survival. And the doublet regimen are no longer recommended. We cannot use a doublet regimen in transplant eligible patients. Also, the three-drug regimen are the standard of care for all non-transplant eligible patients, including VRD or DARA RD. But patients who cannot tolerate three-drug regimen due to poor performance or multiple comorbidities can be started with a two-drug regimen like RD or VD, and a third drug can be added if the BFS improve. Also, the benefit of adding a fourth drug in the primary treatment is emerging with the addition of daratumumab due to better and deeper response rate, better MRD negativity rates, better BFS and overall survival rates. For transplant eligible patient, it is feasible to use DARA VTD, and for transplant ineligible patient, we can use DARA VMB according to Allison trial. And again, lenalidomide mentions both transplant and non-transplant setting lead to significantly improved BFS and trend towards overall survival. Lastly, and finally, cancer, including myeloma, becomes harder to treat with each relapse and progression of disease. So it is feasible and essential to intervene with the best regimen you have as early as possible to ameliorate the course of disease. Thank you.
Thank you very much, Professor Muhammad Abmati, for this very elegant presentation about treatment of frontline of multiple myeloma. Professor Ayman has a question, if you please.
VD light is VRD light. VRD light. It is a modified regimen with VRD. To my opinion, they are using Velcade once weekly with a dose of 1 milligram per square meter. Lenalidomide is used for 14 days every month, not 21 every month. And dexamethasone dose is ranging from 24 to 32. with comorbidities, peripheral neuritis, uncontrolled diabetes, the one who are يعني expected not to tolerate the full dose VRD. But to my knowledge, to my experience, every patient can tolerate VRD.
We sometimes faced with a patient which is very fragile. 80 years, for example, 80 years male with comorbid diabetic, hypertensive, and performance 3. Is any role for Alcran or Licoran? No.
It is better to use Velcade dexamethasone.
If he cannot tolerate, if you give him,
he will tolerate. He will tolerate bortezomib better than Alcran.
Good.
Alcran is very toxic drug.
Toxic على البون marrow, toxic.
On everyone, and bone marrow and bone marrow reserve in this age, and it's not available. By the way.
The only, sorry, Dr. Yasser, the only use of dexamethasone have a rule in these cases.
What?
Only use of steroids. Can you use steroids only?
For what? Single agent? No. You have to add something else. And if you are using dexamethasone, very old studies of dexamethasone are using dexamethasone
14
with a huge dose.
14 milligram, 14?
More than 40.
40.
Which is not accepted now.
Thank you.
طيب سؤال كمان دكتور محمد بالنسبة للجملة الأخرانية with each relapse myeloma becomes harder to enter into remission. دلوقتي احنا شايفين الانكريزنج رول بتاع الدارا والديكلايننج رول بتاع الملفلان. طب البراكتس in Egypt بقى يعني is دارا يعني can be offered to every transplant eligible or ineligible patient ولا والملفلان يعني الرول بتاعه بيبقى دلوقتي
هو there is no ملفلان. الملفلان is used only as IV in transplant.
في الترانسبلانت ineligible.
In every patient. ملفلان IV هيدوز ملفلان only.
تمام.
There is no ملفلان. أنا آخر مرة كتبت ملفلان ده كان من 15 سنة.
بس لسه الفي ام بي بروتوكول ما هو
مش موجود في مصر. بيستخدموش في مصر.
تمام.
وعلى فكرة حتى بره ما عادوش بيستخدموه. بس هو الاستادي كان ده الستاندرد اوف كير ساعة ما بدأت. بس طبعا احنا لو بنتكلم عن براكتس في ايجيبت whenever you have to help your patient to receive triplet regimen or quadruplet regimen with DARA it is better. بس طبعا ده مش متاح في كل الاحوال. يعني ده ممكن متاح في بعض البرايفت كمان. انما الجفرنمنتال يعني you have to start with VRD it is accepted خلاص. وبعدين لو not responding we have to add a force drug زي الداراتوماب او كارفلزومين. انما الفكره ان انت احنا في طريقنا ان احنا نحاول نعرف ودي برضه هتبقى يعني قضيتكم انتوا. احنا نحاول نعرف الهاي ريسك بيشنتس اليونج اللي هم يعني ترانسبلانت كانديد وعايزين نزرعهم بسرعه. هنخليهم يعملوا السيرجينيتكس والسورتد فيش عشان نعرف نديهم نختارهم عشان نديهم الدار. لما كانوا ولا حتى في امريكا كانوا جيف دار تو ايفري ون. انما بليف مي في وضعنا الحالي حتى ايفن في برايفت بيزس انت العيان بتديله في ار دي وبتستجيب. ولو ما استجابش هو كده مش هيزرع. ولو استجاب مش هيزرع على طول. فانت لازم تديله علاج. فانت ما عندكش السرعه او التسارع ان انت عايز تعالج بسرعه عشان تشتغل بسرعه لان مفيش مكان. بس
اتفضل.
In continuation of the question, Turhan, can you give me the absolute difference in progression-free survival and over survival when adding DARA and when you not add DARA?
Absolute difference about 10%.
In months, in months.
لا ما هو الاثنين مش ريتشنج ميديان سرفايفل لان هو الاثنين ما وصلوش ميديان سرفايفل لان الستاديز الميلوما دايما الميديان سرفايفل بتاعها بيوصل بعد 4 سنين.
طب لو قلنا مثلا يعني حضرتك ال 10% ده 2 years survival ولا
3 years
3 years survival 10%
over survival benefit برضه خلي بالك. وبعدين هو دلوقتي بقى في اتفاق على مستوى العالم ان الميديان بي اف اس في عيانين الميلوما بالترانسبلانت 4 سنين وباليوزنج كوادريبل ريجيمن كونتيننج دارا 4 سنين. ودي الفكره اللي هم في امريكا بالذات في بعض السنترز في امريكا بقى بيعملوا لا مش بيعملوا ديل للترانسبلانت لو حصل ريسبونس. بس ده طبعا هيرويك اكسبنسز يعني هم بيعملوا ديلي ترانسبلانت عشان الترانسبلانت عندهم غالي، انما انا ما هعرفش ادي داره 4 سنين، الداره اللي هديها 4 سنين والليل اللي هديها 4 سنين، في الاربع سنين دي انا ممكن اعمل زرع ل 50 عيان فعلا، يعني 50 عيان فعلا. هو الداره يعني فلوسه في كل شهرين ممكن نعمل زرع بيه.
Thank you very much, Professor Mohamed Mati, for your time and effort. Thank you. And now I'm delighted to present Professor Dr. Hussam Al-Achtoukhi, the head of the Medical Oncology Department in Tanta Cancer Institute. His talk will be about the updates in the management of relapsed refractory multiple myeloma.
Thanks, Mr. Chairman. My topic today will be updates in the management of relapsed refractory multiple myeloma. I will complete the mission of Professor Abdul Mu'ti, and I have the honor. This is the background. Multiple myeloma cannot be cured. The goal of treatment is to reduce symptoms and slow the progression or advancement of the disease and both the disease into remission. Remission of multiple myeloma is when most of all signs and symptoms of the disease disappear. Prolongation of remission period was proved to impact disease journey. MRD negativity result in a better PFS and hence better overall survival. This is a diagram of how about there is a real drug evolution. Multiple myeloma have a real drug evolution, one of the disease area that have plenty of drug. And we can see here that the median 5-year overall survival have changed from 25% in the 80s to become in 2010 55%. And I think after we will have more and more improvement. This is the myeloma treatment paradigm or the journey after the usual pathway of induction, consolidation, and maintenance. Eventually we will have multiple relapse until the end refractory disease. My mission today is to cover the relapsed refractory situation. When should we start treatment for relapse? This is an important point. When should we name your patient that it is a relapsed multiple myeloma patient? Patient with clinical progression and CRAB clearly need treatment. If you have evident clinical progression presented with one of the CRAB, so you clearly need a new treatment line. Those with a biochemical progression only may not need immediate treatment, like standard risk patient with a slow trend up. If you have a biochemical progression, and we will define it in a standard risk patient with a slow progression of the markers, you can wait and don't change your line of treatment. But the treatment will be indicated in the case of biochemical progression in the following situation. If you have a high risk disease with any progression, if it is presented with renal or neurological complication, if you have a rapid doubling time of M spike like less than 2 months. Not all the relapse in multiple myeloma are the same. We have aggressive relapse and non-aggressive relapse. The non-aggressive is like the patient with long duration of response, long disease-free interval. The patient have a gradual rise over several months for the M proteins, or the patient have minimal complication or no CRAB at all, or the patient didn't have extramedullary disease. The LDH is in normal range and no plasma cell in the peripheral blood, what we call the plasma cell leukemia. In the contrary, if you have the opposite, we have what we call the aggressive relapse. The International Myeloma Working Group defined the aggressive relapse to be the adverse cytogenetic abnormalities like translocation 414, deletion 17p, amplification of 1q21, or hypodiploidy, high beta-2 microglobulin, low albumin, and the presence of extramedullary disease, high LDH. If you have a short duration of response or progression while on therapy, if your patient is receiving one line and progresses while on the treatment, this is a frank progression and you have an aggressive relapse. Rapid onset of symptoms, extensive disease on laboratory radiography or pathology finding, disease-associated organ impairment, circulating plasma cell, ISS stage 2 or 3, and what we call light chain escape. The International Myeloma Work Group with EHA and ESMO and ASCO and the FDA put define a frank criteria for relapse in multiple myeloma. The clinical relapse will be defined with the following. If you have one of the crab fissure, this is a frank clinical relapse. If you developed a new soft tissue, plasmacytoma or bone lesion, but consider the osteoporotic fracture do not constitute a progression. Your patient may be stable clinically, and sometimes he have a frank pain in the dorsal vertebra. Sometimes it is due to osteoporosis and not due to a new lesion, so don't consider it a frank progression. If you have already an old plasmacytoma or bone lesion, but with definitive increase, but it should be more than 50% and 1 centimeter increase. If you have hyperglycemia, hemoglobin decrease more than 2 grams, if there is a rise in the serum creatinine by more than 2, and if there is a hyperviscosity. This is all are clinical relapse. What is the biochemical relapse? Biochemical relapse means that your patient have increased at least 25% of the lowest confirmed response of the M protein, or 25% increase in the lowest confirmed response between the involved and uninvolved serum free light chain. The ratio have increased more than 25%, or if you have more than 10% increase in the absolute percentage of bone marrow plasma cell. So this all is called biochemical relapse, and please don't rush to change your treatment and evaluate the situation if you are in aggressive relapse or in non-aggressive relapse. General principle for the choosing new line of treatment. If the duration of the initial response, always define the biology. If you have long disease free, so you have an indolent course disease, so be quiet somewhat. We should use triplet, 2 active classes plus dexamethasone, preferred over doublet. At least you should have a new one drug from non-refractory class. Consider performance, age, comorbidity when selecting the drug and doses. Take into account prior toxicity and the residual toxicity. Treat to a maximum response and maintain on one drug until progression or intolerability. How to select treatment? If you have a prior drug exposure or refractory status and the toxicity with prior drug, this will help to decide the specific drug and combination. The age, frailty, comorbidity, patient preference and goals of care, logistics will help to decide dose and schedule. You may choose for your patient all oral protocol and don't to give him intravenous treatment. If the patient is high risk versus standard risk, if the patient is still transplant eligible and the prior transplant, this will help to decide the overall treatment approach and goal. Like we talked with Dr. Abmati, you may put in the plan another transplant if you have a long disease-free interval. Impact of toxicity with prior treatment and comorbidity. How the previous toxicity and the comorbidity will help to choose your drug. If you have peripheral neuropathy and if you have a residual neuropathy, you should avoid the bortezomib and consider carfilzomib or exizumab if you need bortezomib inhibitor in treatment. If your patient have a cardiac failure, avoid carfilzomib and anthracycline if you want to use chemotherapy. In case of renal sufficiency, you know that you might have some renal toxicity. You may avoid or dose adjust if you need the drug. If you have extensive skin reactions with IMiDs, you may choose to avoid this class. Patient preference and logistics. As I mentioned before, we have the exizumab with lenalidomide and dex. All oral regimen allow less frequent clinic visit, but you should follow the compliance of the patient. Sometimes you give the patient oral treatment, but he is not compliant to the treatment. IV infusion require clinic visits. Frequency of administration is an important factor. IV versus subcutaneous has a significant impact on patient choice. Combination with less hematologic toxicity will allow for less frequent testing and clinic visit. As we see here, if you have a plenty of drugs, you have the right to choose between them. But in Egypt, we don't have this luxury. We will divide the relapse situation according to the class used in the previous treatment. First of all, we have the relapse not refractory to bortezomib. Your patient is not refractory to bortezomib, but it may be refractory to lenalidomide, which is a very common situation in Egypt. All of us give VRD and stop Velcade and continue on immunomide. So most of your patient will be lenalidomide refractory. What is the definition of refractory to prior treatment? If your patient progresses on the treatment or within 2 months after ending the treatment, there is a refractory disease. They'll apply to all lines of the treatment, but there is no worldwide consensus regarding this definition. As I mentioned before, a high proportion of patients with newly diagnosed myeloma receive frontline lenalidomide until progression, meaning that their disease will progress while on therapy. This is a very common situation. In this setting, there is no consensus regarding the definition of lenalidomide refractoriness. The patient relapses with a biochemical relapse. If a patient relapses with frank clinical progression and symptomatic relapse while you are in lenalidomide, you should shift your treatment with immediate initiation of alternative therapy. However, if your patient experiences a biochemical only relapse, some clinicians consider that increasing the dose of lenalidomide from 10 or 15 milligram per day to 25 milligram per day and adding dexamethasone before the occurrence of symptoms may be effective, at least in standard risk when relapse occurred during low dose lenalidomide. This situation of the maintenance, you give lenalidomide 10 milligram and the patient give a frank relapse, so you will shift the treatment and stop lenalidomide. If your patient gives just biochemical relapse with a slow progression rate and your patient is in a standard risk, you may continue in lenalidomide with increasing the dose with adding dexamethasone. But there is no clear data are available to support this approach, but some clinicians go this pathway. Really, the only data evaluating this situation is a phase 2 trial from Hovon Group. They evaluated the situation in 67 patients who were refractory to lenalidomide, who well progressed on lenalidomide. Really, most of them were receiving 25 milligram. They only continued the lenalidomide, added cyclophosphamide low dose 50 milligram per day with prednisone, what we call REB regimen. And interestingly, that 67% overall response rate have been found in this group of patients, and the median PFS 12 months, median overall survival is 29 months. This was an interesting result from Hovon Group. So what is the option for our situation? Our situation is the patient not refractory to Velcade and refractory to lenalidomide. What is the option? We have 4 options here: the Castor trial, Endeavor trial, Panorama trial, and the Eloquent trial. Castor trial used DVT, DARA, with VD versus VD alone, and we have amazing hazard ratio for the PFS 0.39, and the Endeavor trial used carfilzomib with dexamethasone versus VD, and it achieved a positive result with hazard ratio of 0.53, and Panorama trial using pomalidomide VD versus VD, and the Eloquent trial, they used elotuzumab VD versus VD triplet therapy with a significant median PFS. These are the options after lenalidomide refractoriness. Really, we have 2 options in Egypt here, the DARA and the carfilzomib. The other situation, your patient is not refractory to lenalidomide. These are the options in our situation. Still, your patient is sensitive to lenalidomide. We have also 4 options. Option from Tourmaline MM1 trial using RD versus exizumab RD. Exizumab RD is the all oral protocol, and we have significant results. We have a hazard ratio of 0.74. The Eloquent 2 trial using RD versus elotuzumab RD, and also we have a significant median PFS. The Aspire trial using KRD versus RD, carfilzomib, achieved a positive results, and lastly the Polix trial using DRD mentioned by Professor Amorti versus RD, and it also achieved an interesting hazard ratio of a PFS, median PFS 0.4. So we have an excellent responses with DARA in our situation, whether in lenalidomide refractory or bortezomib refractory. What is the situation for refractory to lenalidomide and bortezomib, which is a difficult situation a little bit. Here we have some options for our patient. We have the pomalidomide based salvage regimen. You can use pomalidomide instead of lenalidomide with dexamethasone as a backbone and adding a third drug with it. We have the pomalidomide with dex, we have bortezomib with pomalidomide dex, and we have adding carfilzomib, DARA, exizumab, pelituzumab, isatuximab. This is our option, or our option to be added to the pomalidomide dexamethasone. And we have a significant PFS, median PFS a month. All of them are convincing in that difficult situation. Lastly, how do you select therapy for an average patient who have experienced multiple relapse after the patient is achieving multiple relapse, not only the second relapse? Of course, this is a little bit difficult situation. Let's see what we have. The general principles are the same as before: the age, comorbidity, toxicity, and so on, in considering the new line of treatment. What are the options in that difficult situation? We have a new targeted agent and the immune approaches, two approaches, targeted agent and immune approaches. The targeted agent includes the XPO inhibitor, or what we call Celincor, and cell modes, and the BCL2 inhibitor venetoclax, which is well known to us now in Egypt. The immune approach is based on attacking an important antigen on the surface of the myeloma cell, which is called the BCMA, or some calling it PICMA. It is an important receptor or antigen on the surface of the multiple myeloma, and we can target it by multiple ways, like the CAR T cell, the antibody drug conjugate, and the bispecific antibodies, which was the topic of Professor Safa Ramadan, but in a different disease area, non-Hodgkin lymphoma. Let's see what we have. This is a Celincor. It is a targeted agent. It have been approved some response in the STORM trial. We have a median PFS of 3.7 months. This is very little amount, of very little duration, but we know that our patient is heavily pre-treated, and most of the patient receive a median prior line of 7 lines, so it is a very difficult situation. With a median overall survival of 8.6 months and overall response of 26%. This is a trial where Celincor was involved. It was combined with another drug like the VD, like the KD, like the pomalidomide and dexamethasone, and DARA-SD. All of them achieved a reasonable response in a very difficult situation, like with the SVD, with the Velcade. We have in the bortezomib sensitive patient 84% overall response, which is very reasonable in that difficult situation. And in the DARA, with the DARA, it achieved 69% overall response. Celincor have a much higher toxicity, especially when used bi-weekly regimen, and when it used once weekly, the toxicity have been improved much. Moving to another drug, which is a venetoclax. It is a BCL2 inhibitor. It is well known and have established role now in CLL and acute myeloid leukemia. And now here we are using a very high dose. It is a daily dose of up to 1,200 milligram. Has an acceptable safety profile in relapsed refractory multiple myeloma, predominantly in patients with translocation 1114. First of all, it was used in all the patients and achieved a reasonable response, up to overall response up to 20%. However, in the subgroup analysis, have achieved it have achieved a very good response in patients with translocation 1114, more than 40%. This is a Bellini trial. They combined venetoclax with bortezomib and dexamethasone and achieve a pretty good curve for the PFS. We have a clear separation between the two curves of venetoclax with Velcade dex versus Velcade dex alone. However, the overall survival is not significant, but due to the small number of patients. The toxicity, we have higher rates of infection, so infection prophylaxis should be done, and of course tumor lysis prophylaxis. Moving to the new target on myeloma cell, we have, as I mentioned before, the PECMA, BCMA, and another two important upcoming molecules, FCRH5 and GPRC5D. It is an important upcoming molecule to be targeted on the surface of the myeloma cell. You can target this target with the antibody conjugate bispecific antibodies or the CAR T cell. We can look to this illustration. We can target by CAR T cell. Here, this is a myeloma cell. This is the PECMA receptor. We can target it with the CAR T cell. CAR T cell is T cell designated outside the body with a viral vector. It can be engaged with the myeloma cell and release the cytotoxic cytokines. This is a way. We have another way which is called the antibody drug conjugate. We give antibody drug conjugate, antibody loaded with chemotherapy, and here it will engage the immunogenic cell like the natural killer cell to get the battle with the myeloma cell and release the cytotoxic cytokines. Lastly, we have another way which is a bispecific antibody or the T cell engager, bispecific T cell engager. It is a molecule that engages T cell, CD3 positive T cell with the myeloma cell and also release the cytotoxic cytokines killing the myeloma cell. First of all, belantamab is the monoclonal antibody drug conjugate used in our situation, and it achieved a reasonable response around a median PFS of 4.9 with a dose of 3.4 milligram per kg. Also, the CAR T, some procedures have been approved and some are coming near, and they are achieving a good response in our situation. This is a summary of benefit for the bispecific antibodies. The most important is the teclistamab, which have achieved a reasonable response, overall response rate of 63%, and I think it will have a role in the upfront situation in the coming days. This is a comparison of the T cell approach. I have two slides after this, please. Comparison between the CAR T cell and the bispecific antibodies. They are doing a similar job, but there is a real difference. The overall response rate for the CAR T cell is more than 80%. However, it is 55 to 75% for the bispecific antibodies. We have a median progression-free survival of more than 12 months. CAR T cell is not on the shelf. It is a process. It is a therapeutic process. Takes a lot of time. However, the bispecific antibody is off the shelf drug, and it is CAR T cell is doing once. However, the bispecific antibody is a continuous therapy. Conclusion: therapeutic advances have led to prolonged survival in multiple myeloma, but it remains a chronic disease. Treatment of myeloma require a long-term strategy. K is delivering the best package of treatment at a given stage. Optimal combination and sequencing is the K. Risk stratification approach should be done in the clinic. Future will be developing a more individualized approach. Highly effective novel triplets become recently available in the treatment of relapsed refractory situation, also in the setting of lenalidomide refractory patient. New immune therapy represent a new standard of care after third line of therapy, where they significantly improve survival outcome. Multiple ongoing programs with new immune therapies include combination and earlier line of treatment since diagnosis. New toxicities require appropriate management and guidelines. Limited access to CAR T cell remain a challenge in real-life clinical practice. Selection of patient and sequencing of immune therapies need some guidelines. Finally, thank you.
Thank you very much, Professor Hussam, for delivering this very difficult task actually about relapse refractory myeloma. طبعا يعني I don't know how to ask about this بس يعني طبعا أنا I feel بعد يعني ال excellent talk دي إنه to hit fast and strong is better يعني followed by autologous stem cell transplantation. زي ما كان دكتور أيمن بيقول دلوقتي بالنسبة للعيين الفيري فريل اللي هم they experience multiple relapse. طبعا CAR T cells طبعا it's a very long يعني procedure to accomplish وعلشان العيان يوصل له ويعني نعمل separation للتي سيلز ونحملها على viral vector against البي cell maturation antigen. يعني انت شايف ايه يا دكتور حسام؟ يعني هل ممكن في يوم من الايام باي سبيسيفيك تي سيل انجيجر البايتس يعني او your personal experience في المالتيبل ريلابسز بالذات مش في الريفراكتوري تولينا ليدومايد في المالتيبل ريلابسز يعني ما
والحقيقه العيان المالتيبل مايلوما even after multiple relapses still fit and active في معظم العيانين مش كلهم طبعا يعني فبالتالي he deserve a line of treatment. التوكسيستي differ from one to one يعني you should be cautious. You will start the treatment and evaluate your patient. تقيم البيشنت بتاعك وتشوفه وساعات ببدا بلو دوز اند اسكاليت. هي عايزه كلينيكال تالنت في المانجمنت and what we call customization to this patient. احيانا يبقى عين اولد ايج وياخد العلاج ومفيش اي توكسيستي خالص. انا متوقع ان يبقى فيه توكسيستي ولكن هو ما فيهوش توكسيستي. فهي دي الفكره. الكاستمايزيشن بيفرق جدا. الجايد لاينز مش هيقدر يساعدك في الحته دي. انت محتاج تو كاستمايز يور تريتمنت. الكارتي سيل طبعا بروسيس فيري اكسبنسيف زي ما حضرتك عارف دكتور ياسر وفيها لوجيستكس كتير جدا جدا. اي ثينك انها يعني فيري ديفيكالت تو سي نير هير ان ايجيبت. الباي سبيسيفيك انتي بوديز اي ثينك ات از ا جود اوبشن and doing the same job but with a different way but it is on the shelf. يعني ممكن تجيب دواء وتديه للعيان بتاعك. فاعتقد ان هي ممكن تبقى اسهل as a logistics.
بس يعني حضرتك في العيانين اللي هم they experience multiple relapse مثلا في فريل بيشنت حضرتك بدات بدبلت او تريبلت وبعدين ريلابس فممكن تغير العلاج. طب في السكند او الثيرد ريلابس بيبقى متبقي ايه يعني اديهوله ولا بندي نفس الدرج لو حضرتك شايف ان هو مش ريفراكتوري to this immunomodulator او to this proteasome inhibitor يعني لو هو ريفراكتوري طب ما هو the choices are minimized في التريتمنت يعني
هو طبعا الديفينيشن اوف ريلابس دي نقطه مهمه جدا. انا شايف ان هي ممكن تبقى في البراكتس عشوائيه شويه. مجرد العيان يحصل زياده في الام بروتينز ده ريلابس وغير. لا هي مش كده. هي طبعا عايزه نفولو الجايد لاينز في الديفينيشنز بتاعتها ونفرق ما بين العيانين الاجريسيف والنون اجريسيف. ولكن طبعا عندنا مشكله ان في الديفينيشن بتاع الاجريسيفنس هو السيتوجينيتكس اللي هي طبعا في مصر مش بتتعمل از روتين ورك. لان العيان ستاندر ريسك وسلولي بروجريسنج كورس مش لازم اجري على تغيير العلاج وممكن اصبر معاه. ممكن اسكليت الدوز اوف ليناليدومايد لان ده فيري كومن سيتويشن. معظم العيانين عندنا في مصر اخذ الفي ار دي زرع ماشي على الليناليدومايد فبالتالي ده فيري كومن سيتويشن. لو انا العيان بتاعي minimal biochemical slowly progressing disease I may increase the dose of lenalidomide and postpone another option. وسبيشال ان احنا ما عندناش اوبشنز كتيره في مصر ودي نقطه مهمه جدا بتفرق معانا.
والسيلينكس اتفضل دكتور ايمن اتفضل.
When we say no treatment
هذا سؤال صعب جدا يعني هي الفكره كلها بتبقى يعني زي ما بقول لحضرتك
يعني عيان جالك بمالتيبل ريلابس زي ما الدكتور ياسر قال خلاص وخد كل الدراجز اللي انت اديتها له خلاص وانت شايف البرفورمانس بتاعه مش حلو يعني البرفورمانس مش كويس. When you say and you are happy or not feeling guilty go to your home take your analgesic that's all.
لما يبقى العيان اسيمتوماتيك والدواء بيعمل له توكسيستي
لا سيمتوماتيك وبرفورمانس بتاعه يستحمل ياخد علاج بس انت شايف ان العلاج مش هيجيب نتيجه. Go home and take your analgesic and
لو سيمتوماتيك وفي بيشنت I will try chemotherapy. في مصر بتكلم على السيتويشن في مصر بتكلم على الايديال سيتويشن. لو العيان فيت وسيمتوماتيك هدي كيموثيرابي and still it's doing some response in some patient.
انا مش عايز اضايقك يا حسام بس انا هقول لك مثلا في السوليد تيومر I can very comfortably say to the patient no treatment. When you say to your patient no treatment
المشكله دايما في العيان اللي هو اسيمتوماتيك، عشان كده انا بتكلم في الفيت بيشنت. لو العيان بتاعي مش فيت مش هيتحمل الاجراء اللي هعمله، هقول له زي ما حضرتك بتقول نوت
او كلينيكال ترايلز.
يعني انا بتكلم على الريل وول،
على الريل وول داتا.
ثانك
يو.
شكرا.
Thank you very much, Professor Hussam. By this, we will close the session, and thank you for every patient.